Today, we are going to look at a very interesting topic. And our question here is, do autism diagnostic tools consider the contextual and social drives in Black, Asian, minority ethnic children? So, what we are saying here is that when children are getting their diagnostics, are these diagnostic tools considering the contextual and social drives, especially when diagnosing children for autism from Black, Asian, minority ethnic backgrounds? So this presentation will use identity-first language, such as autistic person, than say a person with autism. Black, Asian, minority ethnic is a term that is preferable now in this presentation because the black and white binary paradigm is no longer representative of today's racial landscape. New and old racial ethnic groups have transgressed the color of binary. So, Black, Asian, minority ethnic will be inclusive to all invisible minority ethnic communities. That includes those who are disadvantaged by minority status, such as asylum seekers, refugees, or new immigrants. So I'm using this word to be inclusive. So in 2018, Hayes noted that diagnostic procedures for autism spectrum disorders are not consistent across practice, and that rates can be affected by contextual and social drivers. The social factors that are prevalent in Black, Asian, minority ethnic communities are not the same as those found in the affluent white communities. We are saying this basing on the premise that diagnostic tools were mainly tested and designed around white children and mostly from affluent communities that were able to afford and access services. So in that case, these diagnostic tools were not inclusive of all cultures, all races. So as a result, we need to investigate if the current diagnostic tools are suitable and fit for purpose when diagnosing children from different ethnic backgrounds. So the American Psychological Association describes autism spectrum disorder as a lifelong neurodevelopmental condition which is characterized by difficulties in social interaction, in addition to repetitive behaviors and restricted interests. So, social interaction and interests, all of these can get influenced by cultural beliefs, cultural norms, and how parents also contribute to the questionnaires or the diagnostic tools when they are questioned, especially if they got an autistic child who cannot talk for himself or herself. And what makes autism so complex is the wide variation in expression of the condition. Simply because here You can ask many people who are reading, researching, writing on autism. And each and every one of us, we could come with different definitions of the meaning of autism spectrum disorder. And when one comparing individuals with the same autism diagnosis, one will undoubtedly encounter many different personalities, strengths, and weaknesses. So you can see that we need robust diagnostic tools which can put into consideration all these different personalities, strengths, and weaknesses. So we have got, I'm just going to talk of the main three gold standard diagnostic tools here. I'll just start to talk of the autism diagnostic interview. And there's a revised version. And this is a semi-structured caregiver interview. It is lengthy and not often useful in clinical settings. A powerful approach to gathering information systematically about children and adults with cognitive abilities over 18 months of age. It is commonly used in research. The other one is the Autism Diagnostic Observation Schedule. Again, it is a semi-structured observation that involves interactive tasks. There are several modules on language and age. And if you look carefully on that description of Autism Diagnostic Observation Schedule, it's basically on observation, which makes it very subjective. And if the observer does not understand the culture, the beliefs of the child or the person they're diagnosing, this person who is doing the diagnosis can interpret differently from what is the actual meaning of that behavior. And then we got childhood autism rating scale. This is a measure in which clinicians rate a child on the frequency, peculiarity, intensity, and duration of behaviors, again, such as communication, social development, based on their observation and information gathered during an evaluation. And again, it's based on observation. And when information is gathered, it also depends the caregiver or the parent, what is their understanding of that question being asked at that time? What is the background? What is their ethnical background? Because it influences the type of questions they are likely to give back. For instance, I'm just giving you an example here. I've heard some saying that when Africans are speaking, they wave their hands a lot, they use a lot of gestures, and their voices are unusually high. But in that context, someone not from that culture might think that they are fighting, they are quarreling, or they are angry with each other, whereas they're just happy. It's very common in African cultures that you can laugh and slap your friend on the back, just happens. But in some cultures, it doesn't happen that way. So this kind of gestures could mean something different to the person who is doing the diagnosis. Hence our call that the diagnostic tools need to be reviewed so that they can look and also get tested on Black, Asian, minority ethnic communities. And This last tool I was talking about could take several hours to administer and is rarely used in clinical practice. The other one requires rigorous reliability training, time and expense. And it has got modules, different modules, as I said. But when you look at this one now, it limits again the ability of non-clinicians who are not trained to use it. For instance, I'm calling now that we would like to see more social workers, more teachers, more nurses trained to use these tools. This should not only be a role or a task for a few trained clinicians or psychologists or a few GPs. But let's say we need it more accessible to many people who are working with autistic children in the communities. However, again, these tools cannot be used in isolation. They have to be used with caution with very young children or those with mental age less than 24 months. And Randall in 2018 cautioned that these three tools, ADOS, CAS, and ADIR, are used in populations with lower prevalence of autism. That is, if they are used in those populations, a higher proportion of children who do not have autism spectrum disorder are likely to receive a diagnosis. So there you go. This lack of standardized autism spectrum disorder assessment in real-world settings may contribute to significant variability in a diagnostic across populations. As I'm talking now, I'm quite aware. I've come across research, for instance, from South Africa and some countries in Asia, saying that they've gone through these instruments, they've tested them on their populations in Africa and Asia, and they find that they are well standardized. But how many of these tests have been done is debatable, because it depends with the huge number of those who were tested. If it's a small testing, a small, a research done on a few children and so forth, well, it needs to be more rigorous. Such discrepancies call for a need to review the usefulness of these tools when used on Black, Asian, minority ethnic communities, as they are most likely to be misunderstood due to cultural and linguistic differences, especially that these tools, they are mainly in English. And as I'm talking now, this world is now global. We have got a lot of immigration taking across everywhere across the globe. And we've got a lot of immigrants, again, whose children come into countries with these diagnostic tools, but they can't speak English, let alone that they're coming from different cultures, let alone the fact that these tools were designed for white affluent children the time they were designed, because things are changing. The world is dynamic. So what is the problem again here? The other problem is when we are not looking at the diagnostic tools on their own. The other problem is that autism description, diagnosis has changed from diagnostic and statistical manual time after time, which I'll just call the DSM here. So DSM-3, released in 1980, introduced autism as infantile autism, officially creating a separate diagnosis for autism for the time. 7 years later, a revised edition, the DSM third version, changed the name to autistic disorder, placed it in the category of pervasive developmental disorders, along with other related conditions like Asperger's disorder and pervasive developmental disorders, not otherwise defined. The DSM-5 changed the diagnostic criteria again. Autism and related conditions like Asperger's and disorder and pervasive developmental disorders, not otherwise defined, were collapsed into a single diagnosis: autism spectrum disorder. So again, when the label of autism is applied, educators, psychologists, clinicians, and lay individuals may view the child in a manner that does not necessarily reflect the full range of underlying problems faced in the Black, Asian, minority ethnic communities. So the current autism diagnostic tools do not provide a validated independent measure of any aspect of biological or physiological functioning. And Rantwick, Core, and others in 2016 mentioned that there is much a reason to doubt the reliability of the autism diagnostic tools, given the widening of the diagnostic frame since the notion of autism spectrum disorder became popular. The diagnosis of autism spectrum disorder can be difficult, as I've said earlier, because behaviors seen in a child are often dependent on several non-autism specific factors, such as cognitive functioning, age, language level, source of information, such as caregiver report through an interview, questionnaire, or observation. So during the interview, during a questionnaire, during observation, a lot of interpretation is happening there, and misunderstanding can occur because caregivers may have a different understanding of autism due to cultural and religious belief, which may determine the feedback they give. Potential misdiagnosis of Black, Asian, minority ethnic autistic children may require more prolonged and intensive intervention in the end, may limit their access to appropriate support, may lead to more stigmatization, suffering, and anguish on the part of the child and the family. Race and ethnicity have been identified to influence implicit and explicit biases towards autism. And this is the reason why on my previous presentation, when I was talking of autism in Black communities, I was mentioning that we want to have more clinicians, doctors, psychologists working in autism. Most of them we want more and more from the Black, Asian, minority ethnic communities. If you send the same clinicians and specialists in those communities, in their communities, they understand better the backgrounds and everything. And the families with autistic children are likely to respond positively because they trust them. They know they speak the same languages, they understand each other's cultures. That is why I called that we want autism specialists and clinicians and psychologists dealing in autism, more and more from ethnic backgrounds. There are discrepancies between Black, Asian, minority ethnic, autistic children and their white peers when it comes to diagnosis and intervention of autism. And once again, I call you to look again on my channel and look for the video, Autism in Black Communities. There's statistics and data there that supports that statement. So in conclusion, I would like to say that views of parents and autistic children should be considered alongside the perspectives of professionals to gain a more holistic view of the diagnostic process. I'm supporting Crane here. There's a need to analyze carefully how the current diagnostic tools consider the input of parents and caregivers as active partners. Children from culturally and linguistically diverse communities might be misidentified or under-identified with autism due to the assessment practice employed. And the National Research Council Committee on Educational Interventions for Children with Autism recommended that the best practice diagnostic tools should assess social functioning in a developmental context and should consider the variability of behavior across settings. And the settings must include the cultural, social, economic, and religious factors found in Black, Asian, minority ethnic communities. And current research is showing a weakness of failing to reflect the views and opinions of Black, Asian, minority ethnic communities and acknowledging the existence of contextual social drives. And therefore, there's a need to carry out research focusing on the suitability of autism diagnostic tools when used in Black, Asian, minority ethnic communities in order to ascertain and gain correct data on autism, which goes a long way in determining the provision of suitable intervention. As I said earlier, these tools were designed some time back, could have been designed for white-only communities. We understand that time immigration was not as global as it is getting now. And these tools could not have considered a widely diversified community. So you can read more of this discussion and discourse on my channel. On ResearchGate, you can see all the presentation I'm doing here. Because I prepare presentation, I put it on ResearchGate as well as YouTube. So I'd like to thank you for taking your time to go through today's presentation, and I would like to encourage you to go back to YouTube channel and look at the presentation Autism in Black Communities, because it tallies with this presentation I've done today. Thank you very much.